Extremely interesting case. Young gentleman who has presented to our office with pain to the left foot. We'll say it's a second opinion. Came to see us. Previous. We're not going to get into the details, but where's my marker? Here it is. This is the first metatarsal head, right? And underneath the toe's over here, right? The toe is over here. First metatarsal head, two bones underneath called the, let me make sure that my penmanship is correct. Nice. Sesamoid. Depends which foot, tibial, fibular, sesamoid. In this particular case, it was the tibial, right? No, it was the fibular. So it was the fibular sesamoid. It was removed as a result of a probable, ¿cómo?
Yeah, just treatment after everything else.
Correct.
So,
and the sesamoid, they implemented, treatment that failed, and they decided to excise the sesamoid. The sesamoids play a very, very important role in our gait cycle, in the way that we walk. And sometimes, for whatever reason, we need to excise them. And they went ahead and excised his fibular sesamoid. It's no longer there. So the patient presented with pain, not necessarily a little bit of pain here, but a lot of pain in the rest of the foot. So let's just quickly, let's come around here. So as everyone can see, this is the incision of the previous surgery. They went all the way down. The sesamoids are under here, so they basically picked it out, right? It's like sort of like just like a macadamia nut, right? So they took that out. The problem also is that this is a young gentleman who loves cycling. When I tell you that he loves cycling, he cycles. And I can relate to that because I used to do a lot of the same. And, there's a lot of testosterone, right, out there when you're with the peloton and all of the people and all the groups and you're training and you want to, pedal harder and stay with the group and so on and so forth. But the reason why I bring this up is because we really weren't sure after we sent the patient to the MRI, right? Well, what came out of the MRI, we'll go ahead and discuss that. What was the original cause of what brought him here? So he had the surgery, and when you have a surgery, any surgery, you tend to compensate. You start to move weight from one place to another. So theory number one, we think that that's one possibility, that the surgery was performed and then he started putting all his weight to the lesser metatarsals, second, third, fourth, and fifth. We ordered an MRI which revealed a stress fracture of the second and third metatarsal heads. Second and third metatarsal heads right there. The fourth, no stress fracture, but until proven otherwise, he still has a lot of pain there. The fourth, and the fifth is over here. He still has residual discomfort, degenerative joint disease, most likely as a result of, the past, from not only that, but also from probably, all the activities that you've done in the past, the continuation of again, when we talk about like an athlete, like he's the poster child of that. And when you really exert at that level, and when you operate at that level, something like this could happen. Let's go back to scenario one. That was now scenario two. There was apparently one day that maybe he overexerted too much, pedaling too hard, too much. In cycling, we pedal with a forefoot. So, how many miles?
30.
Not a lot, 30 miles. But the question is, how fast did he pedal through the 30 miles?
Intensity was different.
Intensity, the power.
Not ready.
Right. So you can go from really just, being at a certain level of intensity and then go like this that could potentially create a lot of stress inside the bone. We spoke for a very long time about, what can we do to maximize his improvement. We were both really, honestly, I mean, his pain level is very, very high. And we were both taken by surprise when we saw the results of the MRI. I spoke to the radiologist. I said, "Are you sure these are metatarsal fractures, stress fractures?" And he said, 100%. So I said to him, let's go ahead and we have no choice but to follow what, obviously he's the expert. Let's go ahead and basically marinate the whole area with PRP, the metatarsal heads, and also we're going to go ahead and inject a little bit of PRP into the joint, the first metatarsal phalangeal joint. Why? The sesamoid is intracapsular. We have a capsule over here. We have a capsule. Just like here in the knee, the sesamoid is inside the capsule. So I'm going to go ahead and pour some PRP into the capsule via dorsal approach through the top, okay? It's not numb. This part is not numb. It'll be a little uncomfortable, very little, 0.5 cc's, because he has post-traumatic changes as a result of the previous surgery. So we're going to try to, the purpose number one, injection of the joint where the surgery was performed to lower inflammation and to try to help the whole recovery process. The surgery was when?
March 3rd.
April, May, it was just the other day. It's been a couple of weeks. So that will help. But the second purpose of the procedure today is to try to expedite the healing process. The healing process of the stress fractures. He's numb here. Regardless of the numbness, he may still feel discomfort. Let's go ahead. I think I've done enough talking. Okay, we're going to go ahead and first, and this may be a little uncomfortable. I already disclosed this to the patient. Okay, very, very little. Okay, we've already isolated the plasma. We have exactly 3 cc's of plasma. Let's get a really, really, I like to just kind of go like this just to loosen up the entire joint before we go ahead and here we go. You'll feel a little bit of discomfort, okay, my friend? Pinch in the joint. Here we go. Done. Okay. So now we've marked already again. First, second, third, fourth. I'm going to take the PRP. Pain? Pain? Here we go. Discomfort? Yes? Discomfort? Tell me when to, if you have too much discomfort, please let me know. Talk to me. Too much? Are you sure? Talk to me. We'll stop here. He's looking at me. I know what he doesn't have to say anything. I feel it. I feel it. Because I know I've had this done before. Okay, so here's the third. Here we go. Pain? Here we go. I feel the bone there. Here we go. Discomfort? 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 Okay, I'll stop here. I like to, it's such a dull, achy pain. that it really is uncomfortable. I'm going to go ahead and also inject the fourth, and then I'm going to go ahead and he's had a lot of pain, even though the MRI did not reveal anything inside the fourth metatarsal phalangeal joint. He continues to have, actually, it's kind of bizarre, more pain there than over here. I don't know.
It's painful now.
Nah. Did you guys hear that? He goes, it's painful. There's no editing here.
No?
That's how we roll at Jaws Podiatry. You know, no editing. It's real. Ready?
Yeah.
Okay. Here we go. So I'm going to try to get into the joint here. Pain? There we go. Pain? Okay, we're going to stop there. Yep, that's enough. I know exactly when it's enough because I do feel resistance. The joint is tiny. It's like our fingers, very small joints. And now, the question is, what should we do with the fourth? There's nothing that came out in the MRI. Do we leave this alone? I say we do. Let's focus our efforts on really over here. I'm going to go a little bit more proximal. I mean, yeah. Guys, what should we do? Here we go. Pain?
No. Yep.
Okay, sorry. Pain?
Yep. Ah.
Okay, we stop there. Let's do a little bit more here, and then we're going to be done. Pain?
Yep.
Pain?
Yep.
Not that much?
Yeah, I think that.
Okay, we're done. We're done. Too much. Sometimes the discomfort is...
Yeah, my foot looks huge.
Yeah, it's okay. Even though we were able to... Sweaty hands. I know.
That's because I'm good.
You just grew some more hair on your chest. On a serious note, everyone, and I'll say it again, the reason why, we do anesthetize, these are living cells. We cannot mix living with non-living, right? PRP's living, anesthesia, local anesthesia is not. It's just not. So when we anesthetize, we stay away from the affected area, or the area that we're going to treat. Because if not, what's going to happen to the cells?
Good.
You got it. I don't know if you guys heard that, but basically they're not going to survive. This is, so just so everyone knows, what now? Obviously he's not going to be cycling, so what are we going to do? And what else?
Orthotic.
The patient is going to be strict non-weight bearing. We're going to treat this as aggressively as possible. Why? Because if we're really, really aggressive now, that'll cut a lot of time off so we can get him back to his passion, which is cycling. It's going to be hard because he's not going to be able to cycle, but this has to heal. The problem is that if we, stress fractures can become something more serious, right? Like a true fracture. The bone can crack, and then we have a big problem. So our goal right now is to treat this aggressively. We got the boot, whether it's
The walker.
exactly, whether it's the knee rolling walker, that's my favorite. That's the goal. People call it in Spanish el burrito, the donkey. They call it the donkey. I heard that one. It was kind of funny. The donkey, and that's it. These are tough cases, especially when we do see a lot of athletes do a lot of sports medicine. This obviously falls into the category
1 year dealing with.
1 year dealing with
sesamoid.
the whole thing. This has been a 1 year ordeal. We want to put an end to this, and that's why people come to Jaws. They seek the first, second, then they end up here, and then Jaws. Jaws Podiatry. I'm serious. I'd like to thank the patient for allowing us, obviously, to participate. This is a great case. I love when the patients interact with us, and you guys can actually hear, right? We're not staging anything. They're not reading anything. Our goal right now is to mobilize this. No exercise, eventual physical therapy, and we'll take this day by day. He's in for not necessarily a long haul, but I think that we'll say the 90-10 rule. This is the 10%. The easy part is what I just did and what we did, right, Lisbeth? And then the other 90% now is on him, the patient. Compliancy, following the instructions, following everything that we're going to recommend and have recommended.